He's had a bit of a spat, so hopefully the energy is
right now.
Hopefully the listener doesn't pick up on an energy. Anyway, there was
anger's in the air today.
A 40-minute spaz attack.
Yeah, we just had a bit of a spurg. There was an unnecessary disagreement around terms, antenatal care versus prenatal care, and then it got ugly. But anyhow, I think
water under the bridge.
Usually things are ugly when you're around, Dr. T.
You know what? We're arguing semantics, okay? Let's get into the meat of the topic, which is routine care during pregnancy, okay? Antenatal care, prenatal care, synonyms as far as I'm concerned. So you have a patient, she calls you, she says, "Doc, I'm knocked up. I had ovulatory sex approximately maybe 6 weeks ago. The first day of my last menstrual cycle was approximately 2 months ago. What do I do? What do I do?" Any first ideas about a patient reporting a missed period and a patient who's had ovulatory sex? Well, so sex during estrus.
She had pregnancy tests.
Yeah, so she said, "Yeah, doc, I peed on a stick and it's positive. I think I'm pregnant. It's chaos."
Well, I guess you could ask her what her thoughts are around the pregnancy, or this birthing person's thoughts are around the pregnancy. Are they, were they trying to get pregnant? Were they planning on this? Have they ever been pregnant before? How much?
On good terms with the father.
Yeah, are they in good terms with the father? Asking about, what they know about pregnancy.
The seminal donor, excuse me. Yeah, sorry, go ahead.
Right, we want to use the correct terminology here.
I'm sensing a little bit of more violence from Dr. P, but anyhow.
Father is a bit too humanizing in terms.
Sorry, I didn't mean to interrupt you.
We want to use the term partner.
Okay.
Yeah.
Oh, okay.
Ask about gynae history as well. We want to have our full background on this person. And I guess after those conversations, we can ask about things like risk factors. So are they a smoker? Do they drink alcohol? What kind of medications are they taking?
Yeah, so I think those risk factors are really important, especially active smoking, any teratogenic meds.
Right, yeah. So certainly take a look at any contraindicated medications. Antihypertensives, antiepileptics can certainly be contraindicated. Antidepressants as well as antipsychotics, lithium. You want to watch out for anything that will result in any sort of teratogenicity.
Mm-hmm. And some room drugs as well as skin medications. Remember, any retinols, technically topicals should be fine, but certainly any oral retinoid is absolutely contraindicated. And if they even conceived on some of these teratogens, it becomes a discussion about the risk to current pregnancy.
Right.
Other routine questions in anticipation of pregnancy. Yeah. So of course, was it expected? Had there been any drinking, significant drinking during conception? Have you been taking prenatal vitamin? Locally, the recommendation is 6 months prior to conception. Folks should be taking prenatal vitamin.
Right.
So, has this pregnancy otherwise been optimized? And then that GT-PAL history, PAP status, dates of first day of last menstrual cycle, and importantly, whether or not they were regular. According to our local guidelines, you should offer all women dating ultrasound if it's accessible. Dating ultrasound is more accurate, more predictive of, or better predictive of delivery date than our subsequent
A pregnancy
ultrasound.
wheel.
What's that?
It's
Than
more
pregnancy
accurate.
wheel.
It's more accurate than a pregnancy wheel, which is you basically add 280 days or 40 weeks from the first day of the last menstrual period to get that expected due date.
At least it's cheaper.
It is cheaper, and it's funny that you mentioned that, because for a while we were like, yeah, well, if they were regular in terms of their periods, and they were confident about their dates, you could defer dating ultrasound. That's no longer the case. So we routinely recommend dating ultrasound, which is normally done around 8 weeks, optimally.
Quick note on the supplementation. The big ones to think about is folate, which deficiency in that can result in neural tube defects. And iodine is the other one they ask on exams. So that's important for our thyroid and brain development. I think most folate preparations have iodine as well. But in general, pregnancy multivitamins can come in quite handy.
Yeah. So so you bring your poor lady in. Okay, I'll come into the clinic. This is chaos. And so you see her in clinic, and she's there, and she's nervous, and it's her first baby. And she wants to keep it. She wants to keep the baby. It was conceived with premarital sex, ovulatory.
Ew.
But
Ew.
yeah, sorry guys. She has a good relationship. She's not sure who the father is, but her long-term partner, her common law partner, is the presumed father. So she has a good relationship with him, which is good. So she wants to proceed with the pregnancy. So you suggest some routine blood work. Unnecessary to do confirmatory beta. However, I think commonly we'll dip urine to confirm pregnancy, because we're sending urine for culture. So routinely at that first appointment, you're going to collect your CBC, your group in screen. CBC is relevant because anemia is a common, modifiable risk factor in pregnancy, and there's a dilutional anemia that occurs physiologically as pregnancy progresses. And if they get low, that is, especially hemoglobins in the 110 range or lower, there's always risk of syncopal episode, right? And fall during pregnancy can be serious. So iron supplementation is important. A lot of the prenatal pills will have iron, which of course can predispose to constipation. Pregnancy with increased progesterone is also a risk factor for constipation. So oftentimes they'll split the iron into a 2 dose per day pill, which is a little bit more expensive, but be aware that that's available to you. Other blood work that's relevant are all of your infectious serologies, including Hep B, syphilis, HIV, rubella, and with your urine, you're also going to do a CNS and gonorrhea and chlamydia. One thing that you can consider, and I must say that I'm doing it more often, especially in obese women, is TSH as well as A1C. So there's there's new guidelines, and this is from the States, so a lot of you will be familiar with this. I think it's the American Preventative Care Task Force, who is now recommending diabetes screening at age 35, which of course will capture a lot of your pregnancies. We used to call them geriatric pregnancy. It's probably the average age of pregnancy among most of our peers now. So consider sending off that A1C for diabetes screening as well. And then thyroid, it's not done routinely in our local guidelines. With that said, it's a very important modifiable